Eccoci, siamo online, aspettiamo che qualcuno si connetta. Allora, spero che riusciate questa volta, se siete direttamente chi ci ascolta da casa nel canale YouTube, che possiate mettere commenti e eventuali domande per intervenire e ovviamente aiutare gli specializzandi più anziani a fare domande e ad animare la discussione. L'evento durerà circa 45 minuti ed è pensato in questa maniera: ci sarà una presentazione dei casi, di 4 casi clinici, alla fine di ognuno ci sarà una discussione tra, diciamo, gli specializzandi presenti e Lindsey, che è una fellow presso il Dipartimento di Anestesia e Rianimazione dell'ospedale del Children's Hospital di Filadelfia. Allora, cominciamo. Ora introduco Lindsey e poi cominciamo la nostra lezione. I have a pleasure to introduce Lindsey Shepard. Lindsey is a France and is a Pediatric Critical Care Medicine Fellow in the Department of Anesthesiology and Critical Care Medicine at the CHOP at the Children's Hospital of Philadelphia. And please, it's your time. So good luck.
Great, thank you. Thanks everyone for having me. This is really fun for me to be able to talk with you all. I'm going to be talking about respiratory emergencies in the pediatric emergency department. Go to the next slide. So as Jacopo mentioned, I am calling in from the Children's Hospital, well, from Philadelphia. I work at the Children's Hospital of Philadelphia. And I wanted to mention this because where I practice is obviously very different from where you practice. So some of the things I talk about, we may do things differently, and this is an opportunity to learn from each other. So I really welcome any conversation and questions and discussion about the management of these patients. I'm also going to be asking a lot of questions and asking for your participation, so this can be very interactive. So feel free to interrupt me at any time. And if I'm talking too quickly or you don't understand me, also please tell me and I'll repeat myself. Next slide. Great. So our objectives today are to develop a differential diagnosis for patients presenting with respiratory distress in the pediatric emergency department. We're going to use our history and physical exam to differentiate between the different causes of pediatric respiratory distress. And then we're going to learn how to implement different management plans and how our management plans are different based on the etiology of the respiratory distress. Next slide. First of all, I'd like to just mention that the approach to a pediatric patient in respiratory distress, so first you want to sort of get a sense of whether they're sick or not sick. And so looking at the patient, seeing what their vital signs are, and just having that initial gut reaction can tell you how quickly you need to act and whether you need to intervene or you can talk to the family for a little while before you figure out what you need to do. You always go back to your ABCs, your airway, breathing, and circulation, which is important always in the emergency department. You do your clinical assessment, come up with your differential diagnosis, do your interventions, and I think the most important thing is going back and doing your reassessment. So always going back to look at the patient and see what you've done and whether they've improved or not. So this first case that I want to talk about is a patient with respiratory distress. So you're alerted by the triage nurse that they're coming back with a 14-month-old with respiratory distress. What else would you like to know before going in to see the patient to obtain your history and physical exam? And it actually popped up there. So the answer is the vitals. So you want to know what their initial vitals are. So we can go to the next slide. So their temperature is 38.9 degrees Celsius. Their heart rate is 155, respiratory rate is 40, their blood pressure is 97/54, and they're satting 96% on room air. Are there any vital signs that stand out to you? Anything that looks abnormal to you? Feel free to unmute yourself.
Okay, so temperature.
I wanted to ask, from how many days do he has fever?
Great. So exactly, they have a fever, and a lot of times for us in the US, in the triage, they'll get given Tylenol or Motrin if they have fever in that, but otherwise the vital signs look pretty okay. Their heart rate is a little bit fast, but that's probably related to the fever. Otherwise they look okay. So you said you wanted to ask how long they've had fever. That's a really good question. What other questions are you guys thinking about when you walk into the room?
Maybe we should ask if the child has been taking medications and if this situation is after the medication or it's just like this by the beginning.
Great. You want to ask about what have the parents tried before, what's worked, what hasn't, what's made them better, what's maybe made them worse. Those are good questions.
And also if he has pathologies.
Yes, absolutely. What other medical problems does the patient have? Exactly. Have they ever been in the hospital before? Do they have any chronic medical conditions? Those are all really important and will help you decide what's on your differential as well.
And if he's eating or not.
Very important. You want to ask about whether they're eating and drinking, and most importantly, whether they're peeing as a sign of dehydration. So I often ask how many diapers they're making in a day and whether that's normal for them or less for them, because that can be a sign of dehydration.
Maybe we should also ask if the child has also other symptoms, or I don't know, diarrhea or cough or respiratory distress, vomiting, or others.
Absolutely. Those are all really good questions. You want to ask about all the symptoms that they've been having.
Maybe before we should just be sure that it's not like we need to act in an emergency situation before asking all this question. But actually 96 of saturation in room air, I think it was quite okay. So we had the time to ask questions before acting.
Perfect.
Before like giving something for the fever and everything.
Absolutely. Perfect. So I think we can move to the next slide. So you ask all of your questions, and this is the history that you get. The fever started about 1 or 2 days ago. The highest fever was at 39. He's had a barky cough for the past 1 to 2 days as well. And then this evening started developing noisy breathing and was breathing very fast. So the parents brought the child in. Otherwise, he's not drinking quite as much as he normally does, but is making his normal amount of wet diapers. So like we talked about, probably not very dehydrated. And he has not had any vomiting or diarrhea, no rashes. Nobody he knows is sick, but he is attending daycare, so has contact with other young children. He has no past medical history. He was born full term without any complications, and he has all of his vaccines that he should have as a 14-month-old. We'll go to the next. I think the next is the video. wants to say what they are seeing or hearing with the child there.
Barky cough.
Okay.
Oh, sorry, Margherita.
Bye. Go, Giulia.
I can hear barky cough, stridor, and I can see respiratory distress signs.
Yeah, absolutely. So you said the barky cough, respiratory distress. So he's using a lot of his accessory muscles. You can see he's using the muscles under his ribs, his in between his ribs, and then above his sternum here in his neck. You can see that he's pulling in quite a bit there as well. And then we can go to the next slide. So what, this is just in case the video didn't work. This is your exam, and we talked about all of it. So the next slide. So what is stridor and what causes it?
Okay, so stridor is when you have like a upper respiratory failure. So there is like a tightening of the upper airways, and this is caused often by viral infection or sometimes bacterial infection. And normally it's laryngitis. So we should proceed for the therapy of that one, maybe.
Also, foreign body ingestion, not injection, but inspiration, or yes, laryngeal spasm.
Great. So exactly what you guys were talking about. So it's an upper airway obstruction. So if you look at the pictures that I drew there, if we can pull that up again. So it's an, go back one, sorry. It's an upper airway obstruction. So the obstruction is above the dotted line, which is indicating outside of the thorax, outside of the chest. And so when you take a big breath in, what happens is you increase the negative pressure in your lungs. So you're in outside of your lungs. So you're going to pull the airways that are inside your lungs open, but that causes the airways outside of your lung to come in a little bit more. And so you hear that noise because of the narrowing of the airway, which causes increased turbulent flow. And so you'll hear that high-pitched noise from that flow issue. When you breathe out, you're going to collapse those lungs that are inside your the airways that are inside your lungs, and then the airways that are outside of your thorax, your upper airways, are going to be stented open, so you won't hear the noise. So stridor is primarily an inspiratory sound. So how is that different from wheeze? Because wheeze is a very similar sound that we talk about.
But normally wheezing is comes from lower respiratory airways, and it's the bronchioles that are tightening. So it's a different sound usually. And is it expiratory often and not inspiratory? So we can understand it, which one is, in seeing the time when we hear the sound, basically.
Perfect. That's exactly the point I wanted to make, is that wheezing is on expiration usually. So when you breathe out, you hear it. And that's for the exact opposite reason of why stridor is on inspiration, because like you said, the narrowing is in those lower airways that are inside of your chest. And so when you breathe out, those get narrowed and you hear that noise. So we can go to the next slide. Great, and we can go to the next one after that. So back to our case, we have a 14-month-old boy with 2 days of fever, barky cough, and stridor. What do you guys think that this patient has? You mentioned a few things that you're thinking about.
Croup.
Perfect, exactly.
Or epiglottitis, or foreign body inspiration.
Perfect.
Or other causes of stridor, like abscesses,
yes.
Or allergic reaction.
Great.
Actually, the fact that he has fever make us maybe take off some of them.
Yes, of course.
Perfect.
I think the first hypothesis is croup.
Yes, absolutely.
Yes.
Good.
Infective trigger, yes.
Absolutely. So we can go to the next slide. Great. So croup is laryngotracheobronchitis. So it's a viral infection, usually caused by parainfluenza, causing that upper airway inflammation and obstruction. It usually presents in younger children from 6 months to 36 months, usually in the winter, because that's when a lot of those viruses are going around. And they present with fever, that barky cough, and that stridor, which are pretty characteristic for croup. You mentioned a lot of the things that are on the differential: epiglottitis, foreign body, bacterial tracheitis. And the workup is really clinical diagnosis. So sometimes these kids will get an x-ray, but it's not necessary for the diagnosis. And if you do get an x-ray, you'll see a steeple sign on the x-ray. From that narrowing, you'll see that steeple sign. And the treatment is steroids, which may or may not be indicated depending how severe the croup is. And then if they're having stridor, especially stridor at rest, they often will be treated with nebulized or racemic epinephrine, which can help with some of that swelling in their airway and make them breathe a little bit more comfortably. And then if they need oxygen, they can also get some supplemental oxygen. So what would make you want to admit one of these patients versus send them home after you treat them?
Okay, so maybe we should start a therapy over there and just see, first of all, if the therapy is has an efficacy immediately or not, the first line therapy. Then we should monitor the vital signs and see if they're good or not.
Yep.
Before and after, if it's too severe or not, and if the consciousness of the patient is okay, and if the parents are good parents that can continue the treatment at home.
Yep.
I don't know what else.
Yeah, those are all really good points. You have to think about the family and whether they're going to be reliable and able to take care of the patient. You have to think about whether they're responding to your therapies. So steroids work and help with the inflammation, but they don't treat it very quickly. So it takes a little bit of time for the steroids to work. So typically, at least where I practice, the thought is if you get racemic epinephrine once, that's okay. You can be observed for about 4 hours and go home. But if you require treatment with racemic epinephrine a second time, you have to be admitted to make sure that you're heading in the right direction and not the wrong direction. And the other reason we think about admitting some of these kids is for dehydration. So if they're not able to drink enough to maintain normal urine output and hydration, then they should be admitted as well.
Okay.
Great. Any questions about croup or any comments or thoughts?
I think maybe Gianmaria is speaking but he has mute. Gianmaria, leva il muto. Eccoti.
Okay.
Just
a question. What is the mainly difference between epiglottitis and croup? The shallow rhea?
Yeah. So that's a really good question, how you differentiate epiglottitis and croup. So the difference between them is where the inflammation is, epiglottitis and what's causing the inflammation. Croup is usually a virus that's causing inflammation in just the upper airway, sort of in that subglottic region. Epiglottitis is usually a bacterial infection of the epiglottis, which we actually don't see very often anymore because of vaccinations. So H flu was the most common reason we would see it in the past, and now we really don't see it very often. But you're right that epiglottitis, you have a lot of drooling. Oftentimes you'll see kids sitting in a tripod stance. So they're sitting forward to try and help them breathe a little bit better. And epiglottitis is a true emergency and needs to be intubated in the OR actually by the high trained person because they have a high risk of laryngospasm and not being able to actually intubate them. It's a true emergency. Good question.
Thank you so much.
Anybody else have questions or comments on that? Great. The next slide. So our next case is a 3.5-year-old. She's also coming in with, surprise, respiratory distress. She does not have a fever. Her temperature is 37.7. Her heart rate is 120. Respiratory rate is 42. Blood pressure is 102/58, and she's statting 92% on room air. She's had 2 prior presentations for wheeze with viral illnesses in the past. And she has albuterol at home, which mom was giving every 4 hours with some improvement, but was needing it every 3 to 4 hours, so brought her in for evaluation. She has a cough and congestion for the past 24 hours and increased work of breathing, which the parents describe as fast, hard breathing, since she woke up this morning. She's had 1 fever, which was to 38.8 and got Tylenol for that fever. No vomiting, diarrhea, or rash. She's had normal urine output. Her vaccines are up to date, and she has a medical history significant for eczema. Her family history is also notable for asthma in her mom, dad, and older brother. So what do you guys think is going on here? Sorry, I'll give you the exam first. I think I meant to do that, sorry. So on exam, she's ill-appearing in moderate or severe respiratory distress. She has moist mucous membranes, her heart is regular, and on her respiratory exam, she's very tachypnic with accessory muscle use. So she's using those subcostal, intercostal, and suprasternal retractions. She has nasal flaring and decreased aeration bilaterally with diffuse wheezing in all lung fields. Her belly is soft, non-tender, and no organomegaly, and she has no rashes. So what are you concerned about, and what would you like to do?
Okay, so maybe, as we said before, the wheezing and all the clinical examination make us, and also the clinical history make us think that maybe the child has bronchitis because of the fever, of the wheezing, and so we should treat it. And the fact that the child respond to the bronchodilator make us suggest that maybe we should think about bronchitis or in a child who has like asthma, familiarity for asthma, so more often susceptibility for like this kind of episodes. So maybe we should treat it for this. I think the main concern is to keep the saturation above 92% and start with something in aerosol, such as beta-2 agonist, and then make it think about corticosteroids by intravenous infusion. I think maybe it should be better than an oral intake in emergency.
Or if necessary, iferatropium.
Yeah. Great. Perfect. So I think this is really concerning for an asthma exacerbation. Like she has a family history of it. She's responded to bronchodilators in the past, like you were mentioning. And so wanting to treat her like an asthmatic. And so before we talk about how we treat asthmatics, I think it's helpful to remember what the pathophysiology is of asthma. And so in a normal airway, you see there's like some lining with some mucus and stuff, but which is what you cough up every day when you cough a little bit, but and there's a little bit of muscle around those airways. In an asthmatic airway, you have more of the inflammation, even in a not when you're having an asthma exacerbation, you have more inflammation and mucus in your airways. And then when you have an asthma exacerbation, you get even more inflammation and mucus production, and you get tightening of those smooth muscles around your airways, which leads to that air trapping and obstruction in your alveoli. So you get big hyperinflated lungs, have a lot of mucus and stuff that's plugging up those lungs, and difficulty with breathing your air out. You can go to the next slide. So you talked a lot about a lot of the treatments that we use for asthma. So albuterol, like you were saying, the beta-2 agonist. So it relaxes that smooth muscle in the more distal airways. And steroids, which stop the inflammation and mucus production, are the two really big mainstays of asthma treatment. You also mentioned ipratropium or Atrovent, which is a muscarinic acetylcholine receptor blocker, which also relaxes the smooth muscle, but it's in a little bit bigger airway, so it allows the albuterol to reach those more distal airways. We also use magnesium commonly, which can relax the smooth muscle, and this is used in more severe exacerbations. And then in a true emergency, you can use epinephrine or terbutaline, and epinephrine is usually used intramuscularly, so similar to when somebody's having anaphylaxis. You'll give them epinephrine in their thigh, and this is when they're really not moving any air, so albuterol won't get to the lungs, and so you use the epinephrine, which is a systemic beta agonist, to sort of open everything up and allow them to then be able to get the albuterol to where it needs to go. You can also use terbutaline, which is another systemic beta agonist, which can be given both intramuscularly or intravenously. And it kind of depends on your institution what people do. There's also Heliox, which is a little bit controversial in use in asthma. But the thought behind it is that the helium, lower viscosity, allows ventilation in some of those lower air spaces because of the difference in the oxygen and helium viscosity. And then if you need to, you can use positive pressure ventilation, so CPAP or more commonly BiPAP. And only if you really, really have to do you intubate an asthmatic. And we can talk more about that if there are questions about that. Next slide. So I like to, when I see an asthmatic in the emergency department, there are two big questions that come to my mind that I always ask the family. Has the patient ever been admitted to the ICU, and have they ever been intubated? And the reason why I ask those is because it can give you a sense of how sick the patient can get. If they've been admitted to the ICU 5 times and intubated 3 times, then you're really worried that even if they look okay right now, they could be very, very sick. And so reassessing them frequently is important. And then I think about whether it's a mild, moderate, or severe exacerbation. And there's no real definition of mild, moderate, and severe, but it's more just what bucket you're putting them in and what you think they have. If they're talking to me in full sentences, but have some wheeze and a little bit of respiratory distress, I'll probably call that a mild exacerbation. And I'll give them albuterol with a metered dose inhaler, so the pumps with a spacer that delivers the albuterol actually better to your lungs than the mask and the nebulizer. And I'll also give those patients oral steroids, either dexamethasone, which is nice because you only have to dose it twice, or prednisone, which they'll take a 5-day course of. For moderate exacerbation, usually I'll do the albuterol and ipratropium combined and do 3 of those, and via the nebulizer, so it takes an hour. I'll give them probably oral steroids if I think maybe after that hour of albuterol and ipratropium, they might turn a corner and can possibly go home. and I'll reassess them. And if after reassessment they're still having a lot of trouble, you can consider putting them on continuous albuterol or positive pressure, and consider giving them magnesium as well. And then in severe exacerbation, these are kids who are in severe respiratory distress and you're really worried about them. Those are the kids I'm considering epinephrine or terbutaline in. I'll give them the same albuterol and ipratropium for an hour, but I'll give the steroids IV, do continuous albuterol, and they may or may not need that positive pressure. And then I'll also give them magnesium. And these kids definitely need very frequent reassessments. And I think the trick with asthmatics is really just to assess them frequently. Are they doing a little bit better and we can space out their albuterol, or they're still not doing well and we need to sort of step up our therapy? Questions or comments about that?
I want to ask you something.
Yeah.
I want to ask you, what about lung ultrasound in a respiratory emergency in your department, in your experience?
Good question.
In asthma, also in bronchiolitis, or in respiratory emergency?
Yeah, so I think lung ultrasound is an amazing tool, and actually can be more sensitive in diagnosing pneumonia than a chest X-ray. But it really depends on who you have available in your emergency department to do the lung ultrasound. If you have somebody who's very experienced with lung ultrasound and can do it right there at the bedside, and that gives you a lot of information, then it can be really helpful. But if you don't have that, then you sort of have to use your more classic tool.
Yes.
It also can be really helpful in diagnosing pneumothorax as well. And you'll see when you do the ultrasound, you won't see those B lines or the lung sliding. You'll just see an absence of that. And that can be a really helpful tool as well.
Yes, very interesting. Thank you.
Yeah. Other questions?
So, yes, we have questions from home. This is the question from the chat. Could you clarify the use of Heliox for beta-2 agonist nebulization? Useful or not?
So Heliox,
because it's a controversial point, I think.
Yeah. So I think of beta-2 agonists and Heliox sort of separately. So you're always going to use your beta-2 agonists in asthma. Heliox is if you have a patient who is not doing well, you think they might need some positive pressure or some extra respiratory support, but you don't really want to intubate them. It may have a use there. I brought it up as a controversial point to sort of talk about because I actually have not used it that much for asthma. I think, where I've trained, it was mostly you go to BiPAP and then intubation if you need to, but it is something that some people use. Has anybody else had any different experiences or conversations?
Thank you very much.
Yep. Have any of you used Heliox in asthma? Yeah, it's not very common. Okay, we can go to the next slide. So the third case is a 2.5-year-old previously healthy girl who presents with respiratory distress. Her mom says that she was eating an apple while she was doing the dishes and heard her choking. Initially, she seemed okay, but has had fast, noisy breathing since then, so mom brought her in. On exam, she's tachypnic without any accessory muscle use, and on auscultation, you hear diffuse wheezing on the right side, but no wheezing on the left. What do you think is going on?
Inhalation of foreign body.
Great. Excellent. You're exactly right. Go to the next slide. So I brought this up just to say that not all that wheezes is asthma. So there are many reasons why you can wheeze, and I put the sort of most common reasons to wheeze on the left there: asthma, anaphylaxis, foreign body aspiration, and bronchiolitis. And in the papers that I sent out, there's a chart that sort of talks about the different presentations of wheeze and what you should be thinking about that I think is kind of helpful if you guys want to take a look at that. You can go to the next slide. So back to this case. So you're worried about foreign body aspiration. What would you like to do?
I think for removal of the foreign body, we should like call someone to do bronchoscopy, or not. I don't know if is the surgeon that does it, or I don't know who, but maybe it could help.
Great. So where I practice, and this may be different where you guys practice, we either call the pulmonologist, the lung doctors, or the ear, nose, and throat doctors to come take out the foreign bodies, depending on where it is. So the ear, nose, and throat doctors will come take something out in the nose, in the ear, in the mouth, and partway down your trachea, and then at some point it switches over and the pulmonologists take over. They take the rest of the stuff out. And I just want to mention there's one foreign body ingestion that is an absolute emergency, and that is the button batteries. And I don't know if that's very common for you guys, but kids ingest these button batteries and they can actually do a lot of damage. So that is an absolute emergency, and your time to the OR is critically important to get that foreign body out, because these kids can end up on ECMO and really, really sick. Great. Next slide. So the other thing that when you have a foreign body you can do to try and get a sense of where it is get some imaging, get an x-ray while you're waiting for the ENT or pulmonologist to come by. Oftentimes, if you can see it on the x-ray, that's really helpful, but there are certain types of foreign bodies that you won't be able to see. And so sometimes doing a lateral decubitus x-ray where the patient is lying on their side can be really helpful. So this picture is a patient lying on her right side. So her right side is down. What you can see is that there's a lot of air trapping. So normally when you lie on your right side, a lot of that lung collapses. And so it shouldn't be as big as it is. And it also is a little bit darker, so a little bit more air than on the left side. So that's telling you that there's air trapping there caused by that foreign body creating an obstruction. Great. Go to the next slide. Before we move on, any questions about foreign bodies?
One question. Is it possible, I don't know, is it like a good thing to try to do like Heimlich or something like this before calling for bronchoscopy, or it's better to just wait? I think that maybe it depends on if it's like life-threatening or not, but I don't know. What's about your experience?
Yeah, that's a great question. It depends on how the patient is presenting. So a patient who's actively choking, you may want to try doing a Heimlich or seeing if you can see where the foreign body is and remove it with like a forceps or a McGill. But I wouldn't blindly go into their mouth and try and remove it. In a patient like this patient who has a foreign body, but they're not in significant distress, you can just wait, and the foreign body is so far down that you're not going to be able to get it out just by doing a Heimlich or something like that. The Heimlich really works for stuff that's just in the throat.
Okay, thank you.
Yeah, good question. And Jacopo, how are we doing on time? I think I have 2 more cases, but
I think you presented 2 cases.
okay, great.
No problem.
So the next case is a 4-month-old full-term boy who's coming in with respiratory distress. He's had cough and congestion for the past 2 days and developed increased work of breathing today. He's not had any fever. He's had decreased oral intake and has only made 2 wet diapers so far today, which is decreased from his normal. No vomiting or diarrhea, no rash. He was born full-term without any complications, and he has not had any illnesses prior. He has an older sibling who's 3 years old at home, who is in daycare and also has cough and congestion. So what's on your differential? Is there any workup you'd like to do, and how would you manage this child?
Bronchiolitis, viral induced wheezing, or viral-induced asthma, but at 2 months of, 4 months of year, 4-month-old is quite difficult. So I vote for bronchiolitis.
Great. What would you guys like to do for this patient with bronchiolitis?
Oxygen if saturation is less than 90%, and nothing else.
Fluids.
Fluids, it's necessary.
Is deshydrated.
Yes, of course, yes.
Perfect. I totally agree.
Is it indicated to do an aerosol for trying can resolve with beta-2 agonist at first, and then look how he responds?
That is a really good question and something I wanted to talk about. So there are a lot of guidelines, and a lot of people have looked at steroids in bronchiolitis and beta-2 agonists in bronchiolitis, and sort of trying a bunch of different things. And really the management is, like you guys said, supportive care. So giving them oxygen if they need it, positive pressure if they need help with their breathing, hydration, no steroids. The question you ask, though, is a very good question. And it's reasonable to try a beta-2 agonist if the patient has a significant family history of wheezing, asthma. But without that history, most bronchiolitics are going to wheeze because of just the inflammation in those really small airways. And that doesn't mean that they're going to be responsive. So you can try it and see if they respond, and then use it if they respond, but it's very uncommon to use it in a 4-month-old unless they have a significant family history.
And it's better to use nasogastric tube or IV fluids?
Good question. In the acute setting where you think that a kid just is very dehydrated and needs fluid, you probably need an IV and to give them a bolus of fluids, and then you can start maintenance fluids. But you're absolutely right that nasogastric tubes and giving them fluids enterally is the best way for them. So oftentimes if these kids, if after a day they're not feeding well, we may put in a nasogastric tube and feed them that way.
Thank you.
Yeah. And do you guys, so there's been sort of a change in how we practice, where it used to be if a kid was on positive pressure, so CPAP or BiPAP, we wouldn't feed them in their stomach while they were on that pressure, even like with a nasogastric tube. Do you guys feed with a nasogastric tube on positive pressure?
No, never. Just IV fluids.
Okay. We
never.
Go ahead.
No, I've never used nasogastric tubes. No.
Okay. So now if you're on CPAP, we are feeding kids with a nasogastric tube on CPAP. If they require BiPAP, we usually push it a little further and make it a nasoduodenal or nasojejunal tube. So it goes past the pylorus, but we are starting to, enteral nutrition is really important. And I think it's a recent sort of change in how we think about things. So you're absolutely right that nasogastric tubes are important for these kids. Any other questions or thoughts?
I have a question. Actually, I know that in bronchiolitis, usually you do not, in all the guidelines, they don't suggest the use of corticosteroids. But actually, in clinical practice, often you see patients that are doing therapy with corticosteroids sometimes. And I have the feeling that maybe it's incorrect, because I believe that if everybody is studying about it and everybody is saying that corticosteroids do not help, so I'm sure they are right. But actually I have the feeling that sometimes the use of corticosteroids helps a bit. So it is real that you don't never use corticosteroids in bronchitis. I mean, the question is, you always follow the guidelines, or sometimes you just put it and it's okay?
For us, where I've practiced, I understand that other people want to do things to help their patients, and we'd like to do more. For me, we've always practiced that we don't give steroids in bronchiolitis. If there's a question of whether it's bronchiolitis or asthma, because like Vincenzo was talking about, there can be an overlap, and so if we think it's asthma, they may get steroids rather than bronchiolitis, then they won't get steroids. It's
just a question.
Yeah.
What is the real role of hypertonic saline solution nebulization? The real is a real efficacy to, or is it not a real rule to resolve bronchiolitis?
That's a good question. So hypertonic saline has a higher salt content, and so it helps to break up some of that mucus. So in kids who have really thick secretions and you're having trouble getting them out because they're so thick, that's when I use hypertonic saline. I don't use it that often in bronchiolitis. It's more in if I have a kid who's like intubated and has really thick secretions, then I may use it to break up some of those secretions so I can then suction them out. But the risk of using hypertonic saline is it can cause bronchospasm. And so a lot of times you'll see it given with albuterol to sort of prevent that bronchospasm that goes with it.
Thank you.
Yeah, good question. Great. So we talked a lot about the bronchiolitis. It's a viral infection often caused by RSV, causing that lower airway inflammation and obstruction. That's why you hear the wheezing and all of those other sounds. You'll see it in kids younger than 2 years old in the winter months. They'll come in with cough and congestion. They may or may not have fever. Your differential is reactive airway disease and asthma, like we talked about quite a bit, foreign body aspiration. Younger kids can come in and it sounds like bronchiolitis, but it's actually heart failure. And you can have allergic reaction, or vascular rings and slings can cause some of that airway obstruction that sounds like bronchiolitis as well. The diagnosis is clinical, and you don't need any labs, you don't need any chest x-rays, you don't need anything. And you treat with supportive care. So nasal suctioning, hydration, and they may need some respiratory support, high flow nasal cannula or positive pressure, or some oxygen as well. Just to, so we can continue moving on a little bit, I'm going to just answer this question about when you should admit a patient with bronchiolitis. And it's similar to like what we talked about before, where if the patient's dehydrated, not able to maintain their hydration, that's important. And if they're having significant respiratory distress and you're worried about them from a respiratory standpoint. The other key group to remember is the infants less than a month old. Especially with RSV, there is a risk of apnea. So we often admit the kids less than a month old for observation. Okay, we can go to the next slide. And then this will be our last case, and then hopefully we'll have a few minutes if there's other discussion. But a 4-year-old with no significant past medical history presents with 2 days of cough and fever. Her highest temperature was 39.2. She's been breathing fast since this morning and complaining of right-sided shoulder pain. She hasn't had any vomiting or diarrhea, no rash. She's been drinking okay, but decreased solid intake and normal urine output. No known sick contacts. She's never been hospitalized and has no serious illnesses previously. Mom isn't sure if she has had all of her vaccines, as she's missed some well-child appointments. On exam, she's tachypnic with a respiratory rate of 42. She has subcostal retractions and decreased air entry and crackles at the right base. Her saturations are 88% on room air. So what interventions would you do immediately?
Some oxygen.
Give oxygen.
Perfect. So that's why the vitals are really important. Look at them before you walk in the room. And if you see that they're not saturating well, immediately put them on oxygen before asking all of your questions. So great. What do you think she has and how would you work her up?
I would think about pneumonia.
Pneumonia.
Perfect. Yeah. She has that right
And
shoulder
an X-ray.
pain. Yep, go ahead. Yeah, I think you were saying an X-ray will definitely show you the pneumonia. She has that right shoulder pain, which sometimes can throw people off, but it's actually,
Pleural effusion.
yeah, and it's referred pain from your diaphragm. So if you have consolidation that's right on your diaphragm, it can actually show up as pain in your shoulder. So you would get labs, a blood culture, you would get a CBC to look at her white count, maybe a CRP and a procalcitonin maybe, and probably start her on, since she's requiring oxygen, she'll be admitted to the hospital. So what antibiotic would you guys choose for her?
Amoxicillin.
A penicillina.
Great. So oftentimes when we're admitting kids to our practice is that we start with ceftriaxone if they're getting admitted to the hospital, but you're absolutely right that amoxicillin is the drug we would then transition them to when they're going home to complete their course of antibiotics. What is the main bacteria that that's most commonly causing pneumonia here?
Pneumococco.
Pneumococco.
Perfect. Perfect. And if she doesn't have all of her vaccines, also that can be an indication of pneumococcal as well. So great. So this is a chart that I made that just talks about the different diagnoses that we talked about today. So asthma, bronchiolitis, croup, foreign body aspiration, and pneumonia. And then just goes through their age, etiology, the timing of their clinical presentation, the respiratory structure affected, what you'll see on physical exam, the treatment, and some other considerations. And maybe Jacopo can send out the slides so that you guys can have them if this is helpful.
Thank you.
Yeah, absolutely. And it'll help you sort of, when you see a kid in respiratory distress, to differentiate based on their age and some of their symptoms and what they clinically look like, what you should be thinking about most. But you guys did awesome and got all of the cases really quickly. And it was a lot of fun. So are there any questions or comments that you guys have?
I maybe have a question. It's more a curiosity about this period. Since you work in a very big intensive care unit, I wanted to know, have you had a lot of patients with respiratory failure with SARS-CoV-2?
So I recently moved from New York to Philadelphia. And when I was in New York, I saw a lot more patients with COVID and a lot more of the MIS-C, that like after initial COVID infection, pediatric infection. We are seeing some patients with COVID, but not a ton of them, and more the MIS-C that we're seeing, and some incidental findings of COVID, but not a few patients who are very sick with it, but very rare.
Okay, because I my not big experience, but what I saw is it was that the more criticism in the pediatric patients that we had with COVID were like more abdominal problems more than respiratory problems. So I was wondering if it was just our our experience, or if it's like this everywhere. I mean, maybe in a big hospital you have more possibility to have also respiratory failure or such things.
Yeah, we are seeing a little bit of respiratory failure, and a lot of times it's kids who already have an underlying respiratory problem.
Okay.
But similar to your experience, we're seeing the abdominal issues and then heart issues as well.
Okay, thank you very much.
Yeah.
Okay. Thank you for this wonderful debate. I hope is useful for all of us, and I hope to see you soon in Rome.
Yes.
And you have a lot of new friends, young friends. And good evening and good afternoon for you.
Yes.
Yeah. Good afternoon.
Thank you very much.
Thank you.
This was really
Bye.
fun.
Thanks.
Bye.
Bye. Thank you very much.
Bye bye.